Okay. So it looks like a lot of people have signed up to hear me on the phone, but try to keep on mute. I can hear somebody pretty loud.
Yeah.
I'm busy. Figure it out.
Try to keep your computer or your computer on mute.
Shut up, please.
Okay. Okay, so I'm going to be talking today on thyroid disease, mainly on hypothyroidism. We'll start off with talking about the thyroid gland. The thyroid gland makes two hormones, T4 and T3. T3 is the active hormone that has a short half-life. That is the last. T4 has a long half-life. In healthy people, about 80% of the thyroid hormone that produces is T4, the less powerful hormone. The remaining 20% is T3, the more powerful and active hormone. Most of the T3 that your body makes is active hormone produced by the conversion of T3 into your different bodies. And the body cells do this by converting an iodine molecule with the help of an enzyme called deioxyribonucleic acid. It has a shorter half-life than T4. The T4 remains in the body a lot longer than T3. When you get hypothyroid, your TSH goes up. When you get hyperthyroid or on too much thyroid hormone, your TSH goes down in general. Here's a little chart of that. You have your hypothalamus making a hormone called TRH, goes to the pituitary, it makes TSH, goes to the thyroid, is stimulated. It makes T4 and T3 that goes to the tissue and makes them have the effect of thyroid hormone. It goes back in the bloodstream to T4 and T3 and feeds back at the hypothalamus and the pituitary to keep everything in check. Okay. Okay. What does thyroid hormone do? There. Okay. Thyroid hormone regulates the speed at which individual cells in the body function, or the basal metabolic rate. So it has a lot to do with metabolism. People that have underactive thyroid have a slow metabolism. For example, their reflexes might be slow. They feel sluggish. It's very important in the growth and development of children. A child that is born, an infant that's born hypothyroid won't develop and will have what's called cretinism, which means they have mental retardation. It aids in proper muscle function. It makes sure that the heart, which is a muscle also, pumps effectively and efficiently. So if you don't have enough thyroid hormone, your heart doesn't pump well. It ensures that the gastrointestinal, the stomach tract, is able to digest and excrete food properly. So people that have hypothyroidism can have constipation, delayed emptying of their stomach. It helps make the hair, the skin, and the nails stronger. People with hypothyroidism have weak and brittle nails and hair. Development of the brain. So people that have hypothyroidism, they often say they have brain fog. They feel sluggish. It helps with the growth of bones. It's crucial for development of children and also for adults for their bones.
It's like school.
It's very important for the development of the body's organs. And the thyroid hormone is really one of the most crucial hormones for the whole functioning of the body. For somebody whose thyroid is off, they have a lot of trouble. And it's one of those hormones that even a slight increase or decrease can make a significant difference. That there's a narrow window of what is the correct levels and what is not, and if you're off, it can make a big difference in your health. So what some people recommend, including me, is what's called a thyroid neck check. The thyroid is right in the center of your gland here, and you could do a gland check on yourself. You could take a glass of water, fill the glass of water, put a mirror in front of you, or stand in front of the mirror, look up a little bit, and you have your Adam's apple right about here, a little bit below that, and then you take a glass of water and swallow. You look at your neck and look out for lumps and bumps on it, asymmetry, enlargement. all those would be indication that your thyroid may be off. You could do this a few times if something, if you suspect something abnormal is happening. If you see any abnormalities in this, lumps or bumps, protrusions, you should see your doctor and probably get an ultrasound and get blood tests for your thyroid. This may be a nodule, this may be cancer, this may be an overactive or underactive thyroid. And if you go to this YouTube, you can check on YouTube for for Theodore Friedman for thyroid neck check, you can see an example of it. So how does one diagnose an underactive thyroid or hypothyroidism? So as I said, the TSH goes up when people have an underactive thyroid. So in general, in medicine and endocrinologists like myself, we look at blood tests and we look at signs and symptoms. Somebody doesn't have much signs and symptoms of hypothyroidism, you know, you may or may not treat them depending on how high the TSH is. Someone who has signs and symptoms, then it'll be more likely to treat them. However, there's a lot of people that come to see me that have fatigue and some other constipation maybe, gaining weight, they can't lose weight. The thyroid tests are normal. So it's a combination of abnormal thyroid tests and the appropriate signs and symptoms, including examination of the neck for a goiter. So the TSH goes up. I would say if the TSH is greater than 7, I would definitely treat the person. Then you have a little bit of a gray zone, a TSH between 3.5 and 6.9. So this is sort of the upper normal of the range. And if the person has what I think is the most crucial test for diagnosing hypothyroidism, it's called a TPO antibody. This is the marker for Hashimoto's, it stands for thyroid peroxidase antibody. And if this is positive, it means you have Hashimoto's hypothyroidism, and Hashimoto's hypothyroidism is by far the most common reason why someone would be hypothyroid. Other reasons include somebody had surgery or radiation to their neck, things like that. But for most people, the reason is because they have Hashimoto. So this antibody is crucial. Some people get a test called a thyroglobulin antibody. This test has been shown to not correlate with Hashimoto's, and it's sort of an older test, and the TPO antibody is a little bit of a newer test that's more specific for Hashimoto. So I don't really recommend getting the thyroglobulin antibody. Really, TPO antibody is the one that's helpful. So then you have people, again, with a TSH that's in the high normal range, 3.5 to 6 or 7. You probably treat them if they have the hot positive antibody. Then you have somebody with TSH a little bit lower, have a positive antibody, they might have a goiter, they have symptoms. Some of those people have to treat also, because when they have this positive antibody, it means the gland is sick and more likely to be just coming up. There are a percentage of people that have Hashimoto's that have a negative antibody, about 5 to 10%. So in those patients, if you have a goiter, if you have an elevated TSH and negative antibody, I may get a thyroid ultrasound, which will help distinguish whether the person really does have Hashimoto's. And there are certain characteristics on the ultrasound, like increased vascular flow and heterogeneity on the ultrasound, that can help you decide who should be treated and who shouldn't. There's also a condition called central hypothyroidism, which is due to pituitary problems. These people, and I specialize in pituitary disorders, these people have a pituitary problem. They have a small pituitary, a surgery on the pituitary, something like that. They usually have a low free T4 and a low TSH and some type of pituitary disease. So those people I would also treat with thyroid medicine, for example, because they have a pituitary cause and they can't make enough of the TSH, and that's where their free T4 is low. So people always ask me, you know, Dr. Friedman, I feel really tired, I have a checklist, everything's fixed with hypothyroidism, but my labs are normal. Why don't you just give me thyroid medicine? Maybe try to get better on that. And I think some doctors, unfortunately, do that. I don't recommend that. This is the reason why. Is if you have a healthy gland, your gland itself knows when to make thyroid hormone. It's made at different times of the day. It's made a little bit at different related meals. It's made actually different years, different parts of the year. In the winter, you make a little more thyroid hormone than the summer. And the pills can't replace it. So you're taking a healthy gland that's making the right amount of thyroid hormone and giving somebody a pill that's not as good as the body. So I think that's doing someone a disservice. It's also a little like an addiction. You know, once you start taking exogenous thyroid hormone, it's very hard for your gland to return to normal, suppress your own gland, and then it's hard to stop it. And then by that time, you know, you'll need it eventually if you didn't at the beginning. So lastly, you want to figure out is it a healthy gland or not. So that TPO antibodies gives you a hint that this is a sick gland. It's only going to fail later down the road. You might as well start treating now. If the TPO antibody is normal, it means you have a healthy gland. And I think people that start people in thyroid medicine are doing them a service. And it also helps sort of masking. They have some other problems. They have, Cushing's disease or growth hormone deficiency or iron deficiency, some other problem or menopausal issues that you're missing because you went down this road of going on thyroid medicine. So I think the initial diagnosis who should go on is crucial, and it should be something that's very really considered, especially someone young. So, somebody who's like a teenager comes to me, I'm very reluctant to start them on a medicine that basically they'll have to take the rest of their life. So there's a lot of different treatments for hypothyroidism. And just like for blood pressure, there's different treatments. If you don't put everybody on the same blood pressure medicine, cholesterol medicines, there's a lot of different choices. I don't think the same with hypothyroidism. Everybody needs to go on the same medicine. It should be individualized. So LT4, levothyroxine, is what most people use, and what I use in most patients. The generic is called levothyroxine. There's a brand Synthroid, another brand called Levoxel, which is right now on not available. It's supposed to be coming back in March. Tyrosint, Unithroid, all these are different brands of thyroid medicine that will be that are options for T4. Now, the other hormone is called cytomel, or T3, and I usually don't recommend that. I'll go into a little bit more alone because the T4 is the longer lasting one. I like to use that one as sort of the reservoir, and that longer lasting is usually like a baseline. T3 can give you a little boost. So I usually don't give the T3 alone. I'll talk about that a little bit more. You can do combinations of T4 and T3, and we'll talk about why you may want to do that. There's some new articles that came out. There's what's called desiccated thyroid. These usually come from pig thyroid, and the brands are called Armour, Nature-Throid, IRFA. They're all coming from pig thyroid, and they're all different options for treatment for hypothyroidism. You can do combinations of the desiccated thyroid and T4, and I'll explain why that's also very important coming up. Should be individualized, as I said here before. Okay. And a percentage of people that are hypothyroid that are on T4, somewhere about 15%, have in surveys and studies have a poor quality of life. Again, they would do better if they weren't treated at all, probably. Some of these people are fine. They go to the primary doctor and they're fine, but a large percentage of people, probably somewhere around 15 to 20%, are hypothyroid and properly treated and still are not feeling well. So this suggests that maybe they need some other type of treatment. So two important papers I want to highlight on. One was a paper that was published in the Journal of Clinical Endocrinology and Metabolism in 2009 by a group in the United Kingdom that examined the DNA of the enzyme, the iodinase enzyme that converts T4 to T3. About 15 to 16% of people had an alteration in that enzyme that it didn't function the way the normal enzyme functions. These people did better on a T4-T3 combination. They needed a higher dose of T4. They had more depression. So that suggested from that paper that, again, about 15% of the people didn't do that well on T4 because they don't have the proper enzyme to convert the T4 to T3. A very intriguing paper, and I'm going to spend a little more time on this one, came out from Italy. It was published in 2011 in a very interesting journal that mostly covers basic science research called PLOS1. So because of that, I think a lot of people, clinical people, didn't read it. What they did is they took people that had a thyroid nodule and were not on any thyroid medicine, didn't have any other problems with the thyroid. They got several thousand of these healthy people, and they were able to establish a normal population for this Italian population of free T4, free T3, and TSH. And they were able to figure out almost everybody sort of fit into what this normal range is. Then they took these normal ranges, then they took people that had their thyroid removed for thyroid cancer. They didn't get anything else with thyroid cancer, sometimes with radioactive iodine. They weren't on any other things. Besides that, they didn't have malignant thyroid cancer, they had like benign thyroid cancer. And they had the thyroid removed and they were given back T4, standard treatment there. And they looked at their T4, the free T4, the free T3, and the TSH, and they were all measured, and they had to have a normal TSH. That means that they were properly treated by the conventional way endocrinologists treat people with the underactive thyroid by looking at the TSH. So they all had a normal TSH. 15% of the people that had a normal TSH had a low free T3, and 5% of the people had a high free T4. So this suggests that at least 15%, maybe even 20% of the people aren't converting their T4 to T3 and may need additional medications. And it also shows that when you treat somebody with hypothyroidism, it's reasonable to get a free T3. Most endocrinologists just get a TSH, some get a free T4, but it's shown in this paper that, if you have a hypothyroidism, you're on treatment, you probably want your free T4, your free T3, and your TSH to be all in normal range. And this paper showed that about 15% of the people don't do that. Some alternative doctors measure what's called a reverse T3 to determine that the T4 to T3 conversion didn't work. They didn't do that, and they didn't really need to do that. It showed that by measuring the free T3 itself, which is more straightforward than the reverse T3, that they needed additional treatment, and suggested that these people with a low free T3 on treatment would need a T4, T3 combination. So with that in mind, I think there's a percentage of people that are treated with T4 that don't have, either because their enzyme doesn't work properly or they don't make enough free T3, that they need combination treatments. So I'll talk about a couple of different combination treatments. The first one I want to talk about is Armour thyroid or desiccated thyroid. It's made by a company called Forest Labs, and there is sort of I think a misconception going around by more conventional endocrinologists here that the batches are unstandardized. This is like a small company that takes a bid, and if there's big hyper and there's big hypo, they can have variability in the batches. It's a major company. They have big batches. They do quality control. So I think that's really a falsehood that's not substantiated by the literature that some of the conventional endocrinologists and even the endocrine societies mention that. And I think are completely unfounded. Armour has a higher T3 ratio than T4 than the human thyroid. So if you give somebody Armour alone, they'll end up with a high free T3, a low free T4, and a low TSH. The T3 in general has a short half-life and has to be given twice a day, and the T3 in Armour also should be given, has a short half-life, so the Armour should be given twice a day if you do it. Most doctors don't do that. If they give Armour, they give it once a day, and I think it wears off by the next day. People might feel worse on it, and this may be one of the reasons why Armour got this bad name is people didn't know how to give it, and they gave it only once a day, but next morning the levels might be quite low on it. So it really needs to be given twice a day. They come from desiccated thyroid, and there probably is something in thyroid that's missing in synthetic. And we know the thyroid has other components in it, and it seems reasonable in some of it's not doing well that some of these other components may be helpful. So what I usually do is I usually give the Armour twice a day, and I add back a little bit of T4 to it, because as I said, the T is not enough T4 in it, and you would have a low free T4. So I give back a little bit of extra T4, and I do this in especially the people that are already on T4 that I usually put on people on first, but I add back a little bit of extra T4, and often these people do quite well. Another choice is, again, I said, percentage of people need some T3. You could give no to T4 and give a little bit of Armour to get that extra T3. So some people I try a regimen like that as well.
What happened?
Is there a way to
pick up a cord?
I lost Dr. Friedman. Did everybody else?
Yes.
Yeah.
He'll come back on.
Where did he go?
I don't know. The meeting, the WebEx meeting is flashing on my computer.
Where?
Or it just says no content is being shared.
It's just a breakdown.
Hmm?
It's a break.
Oh man.
Just,
Mom?
Notify him?
I guess we.
Or she would record himself and we could just buy it.
I know.
Did you people try to listen to this on your computers?
You have
Yeah.
to dial in.
We're on an iPad.
You're on an iPad right now, and you can't hear it on the iPad?
Well, it just It said no content is being shared now. Weird.
Well, something happened.
Nothing's going on the iPhone either.
Should we try to leave it and then come back? Scared to leave it. Yeah, never mind.
iPhone, it should be on the iPhone.
Oh, I can try and get back on here. Hold
Crazy.
That's weird.
Well, I see a lot of X's on the people who are listening, but some people seem to have it. I think I'm going to hang up and see if I can get it some other way. Good luck.
Okay, thanks. You too.